just a little bit note about the MR. I think in the last session we had some questions about how long to wait. Typically the literature standard is about 6 weeks. But even if you wait for more than 6 weeks, there's still sometimes some blood product in the prostate gland. So you never know what you're going to get until you scan the patient. So basically, if you wait about 6 weeks or so, you can probably scan the patient after your initial biopsy. All right, I have no financial disclosures. So what we'll do today is we'll kind of take a quick peek at, in general, what the MRI standards, the MRI studies have shown, and we'll rush through the PROMISE and the precision trials because it was covered in the last session. There are some studies out there that kind of do show that even with the standard biopsies, if you do something a little bit different, you can have a pretty similar results as the MR targeted biopsies. And then we'll take a look at the various techniques in terms of MR guidance, and then also I will show you cases from what we have done with using the Untitled setup. Oh, it's the other direction. All right. So we'll skip through the prostate cancer incidence. I mean, it's the third most common cancer that's going to occur in 2018. So it's one of the big issues that we do have, and that's why we're at this conference, right? In terms of the zonal distribution, I think most of us know about this. Peripheral zone is the most common tissue in the prostate gland, and naturally we expect more cancer to occur there. Now, MR is really good in terms of identifying the cancers located in the transitional zone and as well as the central zone, which tends to locate more anteriorly, and that's where the ultrasound has issues, at least in the past. So we'll kind of skip this. We've talked about all the diagnostic workups in the past, in the last session. And again, we'll skip with the PROMISE trials. We kind of all talked, we've seen this sensitivity and specificity is 88% for MR guided biopsies, with trust guided biopsy about 48%. And precision study, again, I think the slide that you should probably remember is this slide where you do have significant increase in detection for the clinically significant prostate cancer, particularly if you have PIRADS 4 and 5 lesions on the MRI. Now, this is something that was used to derive the AUA and also SAR statement. And this is data where it shows that when you have a patient that has undergone prior negative biopsies, the targeted biopsies to produce significantly better results. That is dependent on your PSA range. So as you can see, the repeat biopsies, if you were to use the trust biopsies, your positive rates tends to be around 20%, 10% or lower. Whereas if you use guided biopsies, you can increase that significantly to about 30 to 40%. And this resulted in the AUA and SAR statement, which we'll kind of bypass as we've already talked about that before. Now, this is something that you should know. MRI, again, is not 100%. It is not the greatest thing in the world. It is good for the patients, but again, we have to understand what it is good at. If with Gleason 6 cancers, the MRI has trouble picking up many of them. You will only see about 30 to 40% of them on MRI. With Gleason 7, you get better, about 90%. Gleason 8, 9, and 10, it says 100%, but I think I rounded that one up. It's probably somewhere in the 99% range. So you do get really good detection with MRI for the higher Gleason score lesions. Gleason 6, not so much. So this is probably one of the key points out. Now, we as radiologists know, but also for other urologists, this is one key point you have to understand. And depending on the way you do the MRI studies, there's probably no difference between the 1.5T and 3T studies. All right. Now, there are some studies out there, and that's recently published, that does say that if you were to use ultrasound guidance, you can still get pretty good results in terms of detecting clinical significant cancer. Its actually results are pretty similar to MR guidance. In this study from Europe, they actually looked at 175 patients, pretty much equally divided. And on one arm, they put the patients into MR ultrasound fusion guidance plus the template biopsy. In the other arm, they used strictly the ultrasound systematic biopsy plus any lesion that they could identify on ultrasound. And I have to kind of say, over the last 20 years, the ultrasound system has gotten much, much better. And that for most of you who use this ultrasound regularly, you probably see that the latest systems can show you lesions that you probably would not be able to see in the past. And so this is one of the study that's probably looking more practically at your practices, where if you were to identify a lesion on your trust biopsy, you would probably go after it, right? You wouldn't just let it go. So if you look at it that way, now the clinically significant cancers that are detected are pretty similar. So the detection rate is somewhere between 44% and 49%. For the MRI group, it's 44. For the trust group, it's 49. Now, again, ultrasound, as we all know, it detects the posterior prostate gland really well. When you start going more anteriorly, it becomes more difficult. And the resolution is also a limitation on what you can see. So this is what is showing that there's a population that MRI could detect that the ultrasound just simply cannot see. So with MRI and the trust biopsy plus biopsying the visible lesions, it's more of a complementary role. MRI can detect some things that ultrasound can't see. And when you're doing the trust biopsy, when you see a lesion, definitely biopsy it. Because what it shows is that if you can get those lesions as well, you improve your rate of detection. All right. So, quick summary. MRI-guided biopsy definitely improved detection of clinical significant prostate cancer. And that MRI is limited in detecting Gleason 6 cancer. Gleason 7 is better, and Gleason 8, 9, and 10 is definitely it's near 100%. Now, of course, if you have MRI that's negative and with rising PSA, you definitely do different practices, follow a patient up based on what the clinical guidelines are. Now, the goal of this talk really is to look over the various biopsy methods, especially the targeted biopsies. So we will kind of quickly go over the random biopsies, and then we'll also look more closely at the targeted biopsy with some cases at the end. So with trust biopsies, most of us know, you look at the ultrasound, a little bit fuzzy image in the past, you've probably seen the image much, much better nowadays. Now, it is, in the past, it's difficult to identify lesions, but on the latest system that we have, even at our cancer center, you kind of see the images are much better than what is shown in the traditional literature. Now again, anterior lesions are difficult because your biopsy needle only goes 1.7 centimeters deep into the tissue, and based in my conversation with Mark, you really have to kind of shove that probe to go anteriorly, right? So with the random biopsies, it's difficult to kind of target the anterior lesion. That's where MR really comes in. This is just kind of a statement of what you've all known. Positive biopsy rates for the initial biopsy is about 30 to 50%, and subsequently drops, as we've seen before, down to about 10 to 20%. And limitations with trust biopsies, again, we focus primarily posteriorly. The anterior lesions are difficult to identify. On ultrasound, also, it's difficult to actually see where the most aggressive portion of the lesion is. So there are some limitations to it. It's very, very convenient, though. So, of course, if we want to do a biopsy, we want an ideal biopsy where we can actually locate the lesion, find out the most aggressive portion, and actually be able to reach any part of the prostate gland in order to get to that lesion. And at the end, after you've taken the biopsy, you want to be able to know exactly what you hit. You don't want to say, oh, I'm in that region, but I really did not get the most aggressive portion. So in terms of targeted biopsy, there are several methods. We talked about the Uronav system that you've all known. Artemis is the other option. For us, we have recently brought in the Uronav system, so we kind of have a better familiarity with it. And the other targeted biopsy option is really just freehand under the MR guidance, which is kind of like what you've all known with CT biopsy, right? You kind of work your needle in under CT guidance, well, now you just do it with MRI. And then the last one, which is one that we use most commonly, is the Transrectal MR guided system, where we do everything in the MR scanner, and we kind of get the images afterwards to identify exactly where we hit. All right. So with the MR ultrasound fusion system, there are two steps to it. The first step is that you need a radiologist that knows what they're doing, and so that they can actually mark down the prostate gland for you, and also be able to identify those lesions on the MR and mark and contour those lesions for you as well. When the patient actually goes into your office, then you obtain a different set of ultrasound images, and you yourself have to contour the prostate gland on the ultrasound. At the end, the system infuses both data sets in order to come up with an image for you to guide you for the biopsies. So this is just a screen capture of what you will see. In the upper left-hand corner, you'll see the ultrasound image with the contour of the prostate gland. In the lower left-hand corner is the original MRI with the prostate gland contour, as well as the target lesion. On your lower right-hand side is the 3D generated model by the system that shows you what the path of your biopsy. Now, the advantage is that, as we've talked about this morning, is that this system you can actually do in your outpatient center. It's quick, it's easy to perform. On top of that, you can also obtain your regular 12-core or the systematic biopsy at the same time. The only thing that's a little bit has disadvantages in that you have to have two different sets of people marking down the prostate gland. And then the system at the end fuses the two sets of data sets. These require mathematical remodeling of the data set, so there's probably going to be some sort of error that may occur. In the literature, there's not much data in terms of comparison, but hopefully we will be able to give you more information on that in about 2 to 3 years when we have more data on the Uronav system at our cancer center. The other option is, in terms of MR guidance, is just essentially use it as a freehand guidance. It's essentially exactly the same as the CT guidance. You put the needle in under MR guidance, you kind of go towards the lesion that you want to hit, and then you obtain the samples. So here are some of the images. I have to say these cases are courtesy of Dr. Stephen McCrae from MD Anderson Cancer Center in Houston. In your upper left-hand corner, the image shows the biopsy track that's headed toward a lesion in the right peripheral zone at the midgland level. It's a small T2 hypointense region. In the upper right hand, it's more of the apical peripheral zone, again on the right side. The advantage of this technique is that it completely skirts the rectum. You don't go into the rectum at all, and the chances for sepsis is much, much lower. So perhaps throwing another cog into the discussion is that maybe we don't have to go completely into the peritoneal biopsies, but rather MR-guided transperineal biopsy could be another option. Now, disadvantage is that if you have a big patient, as well, some of us have seen some patients up to 350 pounds, you're going to have a difficult time getting the patient into the bore. You do need a wide bore system that will help you to get the needle in and also the patient. Now, as any sort of freehand system, you do need to manipulate these needles so that it takes a little bit more time to get the patient biopsy. The last system that allows one to obtain biopsy with the MR guidance is the Transrectal MR Biopsy system. What we use is the in vivo Dynacast system, which is now part of Philips. It's an integrated system where it allows us to take the device and actually have the system itself tell us exactly where to go. It makes the biopsy much, much simpler. However, it does violate the rectal wall, and that we do need to give antibiotics as any sort of transrectal ultrasound biopsy. This is the setup that we use. In the upper right-hand side, it is the device. It's made completely of plastic so that it's MR safe. And showing your lower right-hand corner is the needle guide itself that goes into the rectum. As you can see, the size of that guide is about the size of a finger. And on the right, it just shows you that the needle guide is in the rectum and it's pointed toward the prostate. Now, the patient, they will go into this procedure in a prone position. For most of you, the patient is on the side when you do the transrectal ultrasound. For this one, patients go prone. That's the only way we can actually squeeze the patient into the MR in an easy fashion. And usually, based on our experience now, if you just biopsy one lesion, the time that it takes is about 30 minutes. Anytime you have more, you're probably adding about 10 to 15 minutes. And typically what we do get is about 2 cores per site, 3 cores if I'm not so confident on my first shot. So in the literature, it's anywhere between 2 and 4. All right, so this is just a screen capture of what the system shows. In the lower right-hand corner, you have a calibration image that allows you to set up your needle guide well to the patient. In the upper right-hand corner, that's one you use to target. Once you identify the lesion, in the lower left-hand, it shows the coordinates that you adjust the system to. Most of the time, this lesion is pretty good. You might have to, after you get the initial coordinates, you make some minor adjustments to get you to the lesion. Now, we do have to say, when you take the truss biopsies, it's peripheral. Most patients can tolerate that pretty well. Now, when we go deep, when we go anteriorly into the front of the prostate, you're traversing about 3 centimeters of the prostate tissue. Patients don't like it. So that's why we have sedation. It's a different we have options for patients. For those ones who are tough, like most of our VA patients, they could bear with that pain. For some of them, they just simply cannot tolerate it. And so that's why we use sedation to help dull out the pain. When we started doing this, when we traverse anteriorly, every time we move, a patient will moan. It is a lot of pain, so that's why we kind of added that into to help improve the comfort of the patient. The MR sequence that we do is essentially T2-based sequences. So here we'll show kind of a few cases to kind of show exactly what the advantage of this system is. Here we do have a patient that were originally biopsy results were showing the Gleason 6 cancer, and that there is a big T2 dark tumor within the left peripheral zone at the apex. This lesion kind of progressively got darker and progressively enhanced more. So eventually we went in and biopsied this lesion. It came back to Gleason 3+4. So one of the advantages Dr. Cookson has shown is that this system could really help us target the aggressive portion of these tumors so that we can actually upstage the patients. Instead of being actively watched, now we can actually treat the patients. And this is another case where patient has had prior biopsies treated with ADT, yet now the PSA continues to rise. On the right peripheral zone in the apex, you can see on your left-hand side in January 2012, you have a lesion that was small, and that's probably why on the repeat biopsy, using the truss system is initially negative. As it got progressively larger, as seen on the MRI, then we eventually said, oh, that's enough, it's enough, let's go after this lesion. And so we went after that lesion, and the biopsy came back 3+4, adenocarcinoma within the prostate gland. Now this shows one of the advantages of the system, which is you're going after anterior lesions, which you just cannot do so easily on the ultrasound system. Actually, wait, sorry, this one is different, so I was jumping the gun. All right, so here is where the anterior lesion is at. A large lesion anteriorly is hidden from the ultrasound-guided biopsies over a number of biopsies. The patient has had rising PSA over the years and has had negative biopsies repeatedly, so they were sent to us. You do see this large lesion anteriorly that's hidden, and we went after it. Again, with the needle showing exactly what we went through, that came back at 4+3 cancer. So now, the system itself, because of the way we can confirm where we biopsy, it also has the ability to biopsy really small lesions. On ultrasound, I would have to imagine, because I don't do ultrasound biopsy, but I have to imagine that if you were to go in after a 3 to 4 millimeter cancer, a lesion, you're not going to have very high confidence that you actually got the area. With MRs, with this system, here's one case where we have a T2 dark lesion that is about 3 to 4 millimeter in size. And with seen on the axial view and the sagittal view, it is small. But with the MR-guided system, because we can verify where we're going after, we went right through the lesion, and for this case, I believe we took 3 samples, and it came back positive, 3+4. Whereas before, the patient had repeated negative biopsies. So this kind of shows the system where, if we're really going for the anterior lesions or we're going after the smaller lesions, this system can help you verify that, hey, we really got the lesion that we wanted to. But again, nothing is perfect, right? So with these limitations, with this system, if you have a huge prostate, if you have a prostate that's over 150 cc's in volume, It's difficult to reach the base and also apex, simply because the range of the device isn't completely designed for that. And also, if you were going after very lateral lesions, it's also very difficult. There are ways around it. You can kind of curve the needle a little bit and actually extend that out a little bit further. But it is much more difficult to reach the extremes of a large prostate. Now, with this system, because we're kind of going in and out of the MRI for confirmation of location, it is difficult to obtain the systematic biopsy if we need it at the same time. The advantage, again, is we can see the biopsy track going through the lesion, and we're able to biopsy very small lesions. So overall, we do know, with combination from last session, we do understand that MRI can improve the detection of clinical significant prostate cancer, and that MRI guidance do increase the yield of those biopsies. It is efficient, but what we also have to know is that the baseline technology itself simply cannot detect all the Gleason 6 and Gleason 7 cancers. Gleason 8, 9, and 10, much better, and it's probably a great technique. All right, with that, I'd like to thank you for your attention.